Good morning and good afternoon to everybody. My name is Kishore and I am the event manager with Compliance Key Incorporation and would be your today's host. Thank you everyone for joining in today's live webinar, Legislative and Regulatory Enforcement Update. Today's presenter is Jay Einstein. I will quickly introduce Jay. Jay is currently Compliance Officer for Advanced Medical Imaging Consultants. Mr. Einstein oversees the compliance program and serves as the group's contract administrator as the compliance officer for this radiology practice. Since 2001, Mr. Einstein has advised physicians, senior management, and board of directors on numerous regulatory compliance issues impacting healthcare operations. Now, before I hand over it to Jay, I should inform you that the session would be of 75 minutes and also we have Q&A session at the end of the webinar. You can keep sending your questions through chat window and Jay will answer those questions at the end. We will begin now. Jay, I would request you to please start the presentation.
Okay, great. Thanks, Kishore. My name is Jay Einstein. I'm a healthcare lawyer that specializes in regulatory compliance. Just a little bit of additional background on me. I have been in healthcare for about 20 years. I've worked on the managed care side of the market, the provider side of the market, for large health systems consisting of a couple 100,000 employees and small physician-owned entities consisting of about 20 employees. And in that time, I've definitely grappled with monitoring and confronting various regulatory enforcement challenges over the years as new regulations have been passed or existing regulations have been changed. And so what I thought I'd do today is just talk through just kind of a current snapshot of sort of where we're at in 2016 with regards to legislative and regulatory enforcement. So with that, let's go ahead and get started. Just an overview of where we're going in the next 75 minutes. We're going to talk through basically two main areas. We're going to talk through fraud and abuse and the fraud and abuse regulations, highlighting what the basic rules are, any particular notable settlements that have come up in the last couple years, as well as some enforcement trends, and then I'll add in some legislative updates as well. Then we'll do the same on the patient confidentiality side, just talking through just notable settlements and enforcement trends, and then legislative updates as well. And then if there's any questions, I'd be happy to take those questions at the end. So in terms of fraud and abuse, I had attended a compliance conference earlier last year, and the head of the OIG, Daniel Levinson, had spoken a presentation and gave this acronyms. I know we all like our acronyms in healthcare, and I thought this was a particularly easy one to remember for the fraud and abuse laws, FACES. And so what we're going to do today is really talk through the False Claims Act, the Anti-Kickback Statute, and then the Stark Law. Sorry, I'm just going to go back a sec. The Civil Monetary Penalties Law and the Exclusion Statute, those essentially are just additional weapons that the government can use in their arsenal when they go about prosecuting fraud and abuse related cases. And so because of their technical legal nature, they're not substantive laws. I'm not going to go into detail with those, but instead focus on the False Claims Act, the Exclusion Statute, and the False Claims Act, the Anti-Kickback Statute, and the Stark Law. So just looking at the False Claims Act, general rule is it prohibits anyone from knowingly presenting a false or fraudulent claim seeking payment to the federal government for a federal government program. This is a particularly old law. It's also referred to as Lincoln's Law. It came out back during the 1860s in the United States when the Union Army was fighting the Confederate Army in the Civil War. And there were groups of individuals that were contracted out with the federal government to provide various weapons and supplies to the Union Army to fight the war. And similar to 2016, back in 1863, you're always going to have a group of individuals that are trying to game the system by doing things that they're not necessarily, or saying that they're doing things that they're not necessarily doing. And so in that case, they were providing guns that didn't shoot, faulty equipment, horses that were not fit for battle, and food that was rancid and things like that. So where we're at today in 2016 in healthcare, we obviously have Medicare, Medicaid, TRICARE, other government health type programs that brings in the applicability of the False Claims Act with regards to submission of claims for services provided. So just your typical False Claims Act type cases that we see in healthcare, services never rendered but claimed to be rendered, duplicate billing, no documentation or lack of documentation of medical necessity, and that has sort of been a trend that's been on the rise that we're going to talk about in a little bit here with a couple cases. Unbundling, which is essentially using a code or using several individual codes when there's one group code that exists so that you get increased reimbursement. And then billing for services that are based on a Stark or Anti-Kickback violation. And again, we're going to talk through a couple cases that are going to highlight that particular point. In terms of the penalties piece, there's a civil penalty that's almost $11,000 to $21,000 per false claim. For the first time in about 20 years, that number actually just recently went up. It used to be $5,500 to $11,000, but then Congress last year, in order to account for inflation, the fact that the penalties hadn't increased over the years, essentially directed all the federal agencies to go back and increase their penalties. And so Department of Health and Human Services had settled on this $10,781 to $21,563 amount. And so one thing to pay particular attention as we go forward is a lot of the cases we're going to talk about, this particular increase in the penalties just happened August 1st. So the cases we're going to talk about were all settled prior to that. And so when we look at the amounts of money that were being paid out to settle these cases, you can take that now times double to get an idea what the penalties will currently be under the False Claims Act. The money can definitely ratchet up because the government is allowed to charge 3 times the amount of damages that are sustained by the government. And then there's exclusion from federal health care programs such as Medicare and Medicaid, which I know most organizations that usually makes up about 30% of their business. So that could be quite a blow to a business's profit margins when 30% of their business is lost. So you definitely do not want to be excluded from participation in a federal program. Just looking at some notable settlements. This first case, Riverside General Hospital, this was one that was settled in June of 2015. It's a case that came out of Houston, Texas, and it's notable for a few reasons. One is the dollar amounts involved. It was a $158 million settlement relative to billings to Medicare that covered a 7-year period by the hospital. There were 4 individuals that were involved in this. It was the CEO of the hospital, it was his son, and then a couple co-conspirators. And the scheme that was going on here was related to partial hospitalization services, or PHP. And if you're not familiar with that, PHP is essentially a form of intensive outpatient treatment for those with severe mental health illnesses. And what happened was the CEO and his son and these co-conspirators had engaged in a scheme where the hospital would pay money to recruiters from group homes for those with mental illness. They would pay them money in order to send them patients to the hospital, and then the hospital would bill out for those PHP services to Medicare. And in a lot of cases, or I should say the cases involved with this particular suit and the monies that was being billed out to Medicare, they involved medical necessity issues, and that these patients didn't actually, either they didn't actually qualify for PHP services, or they were never provided, or the patient never did see a psychiatrist as part of that treatment. There were some patients, unfortunately, that had Alzheimer's, so they were not completely aware of what was going on. And so I think that's reflected in the monetary amount of this particular settlement and the message that the government was trying to send to the hospital. In addition to the fact of the prison time that was involved for those that were involved in the arrangement. So the CEO ended up getting 45 years, the son got 20 years, and then each of the co-conspirators got 12 years. So a lot of prison time involved relative to this particular case. Again, I think it's because of the egregious nature of what had happened in terms of the amounts being billed, and then the vulnerable state of those that were being taken advantage of. Another case you may have heard of, this got quite a bit of news a couple years ago. Michigan Hematology and Oncology. This was a group, physician practice, Dr. Farid Fada out of Michigan. He had settled in September of 2014, but it got a lot of press a year ago, last summer, in December 2015, when he got sentenced. But bad set of facts, unfortunately, in this, kind of like the Riverside General case, in that Dr. Fada was actually diagnosing people with cancer that didn't have cancer, and then unfortunately having them undergo very expensive, very invasive chemotherapy and other types of treatments. And then, of course, billing Medicare out for those services. He had billed out about $17 million over about a 6-year period. And there was about 550 patients that were involved total. And the reason why it had made the news was he was eventually convicted, and he was sentenced to 45 years last summer, which he's about a 50-year-old gentleman, and so it's effectively a life sentence for him. But cases are notable for a couple reasons. Obviously, kind of an interesting set of facts in that a lot of these False Claims Act type cases, you're going to have a situation where somebody is saying that they're doing something and they're not actually doing it. Here he actually was providing the service even though the person didn't qualify for it. And so it was definitely a medical necessity type case that had come up. I did hear a presentation earlier this year from Leslie Cardwell. She's one of the attorneys with the Department of Justice that was involved in the case, and had spoken about, obviously a very egregious set of facts that had happened. But if there was any type of silver lining on it, she felt like there was very quick action on the part of the government to shut the practice down. And how this had come about was Dr. Fada went on vacation, and there was another associate within his practice that was seeing a patient. And in looking through the patient's records, I could not find anything to suggest that this particular patient actually had cancer, which obviously made him very concerned. And so he had connected with the administrator of the practice, and they both turned that information over to the government. And then within 48 hours, the government had shut down the practice while they did the investigation. So the only good news in this was a very quick action on the part of the government to shut that practice down, but obviously a bad set of facts. Kind of a similar case, unfortunately, came about around the same time, was the Spastis Health System case. This was out of Florida. And it involved billings to Medicare and Medicaid for MS treatments, and kind of similar to the Dr. Fada case in that I had a couple neurologists that were actually diagnosing patients with MS that didn't actually have MS. And the reason they were doing that is because they had been given essentially a kickback scheme from a drug company that produces drugs for MS treatment, and that anytime they had placed a particular patient on their drug, they received a payment for that. And so that was sort of the motivation for why they were doing this. And so this was a whistleblower-driven action. It involved a patient that had gotten a second opinion. And the second opinion had determined that there was absolutely no indication that the person had MS, which led to a lot of questions, and eventually led to this False Claims Act case. The False Claims Act side did actually settle with the hospital. I know that there's also pending litigation from a personal injury standpoint against the physicians involved, so that will be kind of interesting to see sort of where that goes. But again, I think a very sort of scary trend out there with these medical necessity type cases and services actually being performed that don't need to be performed, I think is something that we're, at least from a public perception standpoint, first starting to become aware of these types of cases. So I'm not sure if others are out there, but I do hope that this is a trend that does discontinue. The last notable settlement I wanted to talk through was with regards to the False Claims Act. With regards to the False Claims Act is this mass hospital settlement that came about last November that involved implantable cardiac defibrillators and noncompliance with Medicare's National Coverage Determination guidelines related to implantable cardiac defibrillators. 457 hospitals in total all across the country had settled for about $250 million. The money amount probably is not that shocking, but the number of hospitals involved, I think, is interesting, which makes this a notable case. And what had happened was, with regards to the noncompliance with the NCDs, what these hospitals were doing is, according to the NCD guidelines, if you've had a heart attack, the guidelines dictate that you're not supposed to have an ICD implanted within 40 days after that bypass, or 90 days if you've had angioplasty. And so what happened is the government had done extensive medical review involving these hospitals and their compliance with the NCD, and found out that there were a lot of situations where patients were implanted with these devices inside these particular time frames. And so it's my understanding the reason why they have these time frames in place is to be able to give the heart the opportunity to try and restore its function to potentially alleviate the need for an ICD. And so that essentially is what was going on in this particular case that led to this very large settlement and, very large number of hospitals that were involved. So just some takeaways on the False Claims Act cases. Again, quality of care, medical necessity cases, these definitely seem to be on the rise. False Claims Act cases in and of themselves, about 85% of them are typically whistleblower driven. There has been kind of an increasing number of cases that are actually driven out of data mining that goes on within Medicare and other government agencies that leads to these particular settlements. But I think it's just interesting to highlight that this is becoming of increasing importance to the government, and we'll kind of see where things go with regards to value-based payment, some of the other payment models that have come out in the last couple of years. Something I would advise if you're not doing is just making sure that you're conducting routine NCD and LCD monitoring. Make sure that you check with your MAC what the particular guidelines are that they follow. You're getting updates to those NCDs and LCDs. If you have clinical departments within your organization, make sure that you're doing routine monitoring of those with those particular department leaders, those subject matter experts that are going to be most aware of what's going on in their departments and whether they are or not complying with the NCD and LCDs. And if you identify areas where you're in noncompliance, of course, making sure that you engage in a form of corrective action to correct that conduct. And then also just sort of more globally, just making sure that you're conducting auditing and monitoring just to sort of spot check, that you do have appropriate documentation to support medical necessity and support the services that are actually being provided. So shifting gears and looking at the Anti-Kickback Statute. The Anti-Kickback Statute makes it a felony offense, so that means criminal, to knowingly and willfully solicit, offer, give, or receive remuneration in exchange for referrals for items or services covered by federal healthcare programs such as Medicare, Medicaid. That's sort of the general rule. Remuneration is just a fancy word for anything of value. And safe harbors I highlighted there, those operate essentially like an exception. In the Stark Law, when we get to that, you're going to see we have exceptions. The Anti-Kickback Statute has what are called safe harbors. Sometimes the two laws mirror each other, and in other instances, they are a little bit different. But essentially, just to give you an example, we're going to talk about a lot of physician contract-related cases today, and there are safe harbors within the Anti-Kickback Statute that essentially provide that you need to have agreements that are signed, and compensation to the physician has to be fair market value, or if any money is exchanging hands, it has to be fair market value. And you can't take into account volume or value of the referrals or business that's been generated. And so As you're looking at your particular contracts, those are the things you want to make sure that you've got in place so that you're meeting those safe harbor requirements, so that you're not getting yourself in trouble with potentially violating the Anti-Kickback Statute. In terms of penalties under the Anti-Kickback Statute, up to 5 years in prison, criminal fines up to $25,000, civil penalties up to $50,000, and then again exclusion from participation with Medicare and Medicaid. Looking at some notable settlements in this particular area. First case I want to talk through is Millennium Health. This was a case that got settled last October, and it had to do with free drug testing cups that were given to physicians. Millennium Health, if you're not familiar, they're a large company based out of San Diego that provides laboratory services and do a lot of urinalysis testing. And what they were doing is they were engaging in what were called cup agreements with referring physicians. And part of these cup agreements were such that if you had signed one of them or agreed to receive these free cups, you had to collect the specimen, obviously, from the patient. You would then have to send it into Millennium for the testing. You couldn't bill the patient's insurance, and then you got the cups for free. And then also, if Millennium came back and said, well, the patient needs additional testing, you then have to use Millennium Health. And if you complied with all those different criteria, then you got the testing cups for free. If you didn't comply with that, then you actually got penalized and had to pay for the cups. And so relatedly, as we'll kind of talk through, there were some Anti-Kickback Statute and False Claims Act allegations that were attached to this particular case. With regards to the Anti-Kickback Statute allegations, so obviously the free cups under the Anti-Kickback Statute, that's going to be considered something of value. And again, they were given to these physicians on the condition that they were going to send business to Millennium. And if they didn't send business to Millennium, then they had to actually pay for the cups. And so how that was set up essentially is going to be considered an inducement to refer patients to Millennium. And that's what got them in trouble with the Anti-Kickback Statute. On the False Claims Act side, so how these particular cup agreements worked was the physicians had to order Millennium's custom panel, which, surprise, surprise, was their most expensive panel. It basically tested everything and anything that they had offered. And so the problem with that is that whether or not you needed the things that they were testing, you got one of those tests if you were a patient. And so essentially this boils down to the fact that there's no actual individualized patient assessment with regards to ordering these particular panels, which then gets you into a lack of medical necessity issue, and that ties you into a False Claims Act type violation. So for Millennium, where things had all settled is they ended up having to pay $256 million to settle this particular case. And again, it involved the Anti-Kickback Statute violations and the False Claims Act violations. And then they had to enter into a corporate integrity agreement for 5 years. Just a couple of additional points on this. The corporate integrity agreements, if you're not familiar, these essentially operate, I always like to think of it as like probation. So it's an agreement that the Millennium would have to sign, and they're going to get a government monitor that's assigned to them for the next 5 years. They're going to have to do periodic check-ins with that monitor. They're going to have to provide certain documentation, potentially employee interviews, other things that are going to demonstrate that they're doing the things that they said they were going to do as part of their corrective action under the CIA. And then once they do those things, the CIA eventually goes away. But this is sort of one of those things where the gift kind of keeps on giving, even though you've settled. The busy work of having to work under the government scrutiny is going to last for the next 5 years. So definitely not something that you want to do, and it's sort of a byproduct of a lot of these settlement type cases, but I wanted to sort of call it out in particular to this particular one. And then the other thing to notice is just the dollar amount involved. So this was $256 million that was settled, which, you know, for an organization, of Millennium's size, you might not think that seems like a lot of money, but they ended up having to go through bankruptcy protection reorganization, and they had about, I think it was about $1 billion in debt that they had to restructure, and a quarter of which was this particular settlement. So these fines and penalties can sting, and in the case of Millennium Health, it was definitely one that had stung, and that was the message that the government wanted to send. Next case is the Citizens Medical Center case. This was a case that came out of Texas and was settled last year. And it involved a couple different situations that were going on. Primarily it was cardiologists. So this was a situation involving employed physicians. In total, there was about 24 physicians involved across 6 different specialties, but the main focus of the case was on the cardiologists. And then there were some ER physicians that were involved as well from a kickback standpoint. And essentially this case had to deal with the physician compensation being in excess of fair market value under the safe harbors to the Anti-Kickback Statute. So what was going on in this particular case is there was a group of cardiologists that became employed by Citizens. Citizens had bought their practice out, and these particular docs became employed. And by the numbers, their salaries back in 2006, before they were bought out, on average was about $630,000 a year. Then in 2007, which was the year that they got bought out and the first year of their actual employment, their salaries increased to roughly $1.4 million. So definitely a little bit over double what they were getting paid previously. And so that is something that clearly was outside the scope of what the market would bear and seen as something to try and intentionally induce them to steer more cardiac-related cases to Citizens' facilities. The other thing that's interesting to note with this case was at the same time this was going on, the practices, once they became employed, were losing money. In 2008, they had lost about $400,000, and in 2009, they had lost about $1 million. So they're losing this money while they're paying these extraordinarily high salaries to these particular physicians. And I'll point out why that's important here in a second, but that was sort of the main crux of this particular case. And then the other spinoff to this was the ER physicians that gotten pulled in, because there were a group of ER physicians that were getting bonuses for cases that they were handling and sending in-house related to cardiac referrals. And so those particular bonuses were seen as a kickback. So under the Citizens case, where this had shooken out in terms of the settlement was the money that was being paid out to the physicians was salaries that were in excess of what the market would bear. And then they were considered commercially reasonable, which is one of the other elements that you need to pay particular attention to with regards to complying with the safe harbor for your physician contracts. And when you look at the fact that they were getting paid these high salaries, but the practices were losing money, would that make financial sense for Citizens to be paying them those high salaries? And of course, it doesn't make any sense. And so that's the problem that you run into with not meeting this commercial reasonableness test, and that's what had happened in the Citizens case. Clearly for the ER physicians, compensation was being taken into account in terms of where they were sending their patients, so they were getting kickbacks. And then all said and done, it was about a $21 million or $22 million settlement that was involved. So just some takeaways with regards to these anti-kickback type cases is, just be aware of your sort of subtle business arrangements. If you haven't already done so, and I'm not sure in your organizations if you're involved in monitoring your contracts for compliance, but it's something that you should talk with your leadership team, and if you've got legal counsel involved or you have legal counsel available, talk with them to make sure that you're doing some type of spot check on your particular physician agreements to make sure that you're in compliance with the Anti-Kickback Statute. things that you're going to want to do, again, is just making sure that you have agreements in place, that they're signed, that you have a third party or some type of independent evaluation that can establish that the amount of money that's being paid out is fair market value, so that you could defend that and have the documentation to defend it should you get audited or investigated by the government. And then making sure that any payments that are being made are being paid out according to the terms of those particular contracts. Definitely an area of focus is these employed physician cases. I included some other ones up there. It's the scope of this webinar is such that it'd be too extensive to go into these other cases because they're very complex, but the Toomey case, the Halifax case, and the North Broward, actually we are going to talk about North Broward here in a little bit, but these are all cases you could definitely do a general Google search and find information, but they were cases involving physician compensation of employed physicians. And I think for a number of years there had sort of been thinking within the industry that, well, when you have physicians that are employed, you don't have quite as much of a concern as you do with the physicians that are contracted in terms of meeting these anti-kickback and STARK type requirements. And these particular cases send the message that that's definitely not true, and that you need to be careful about your employed physicians as well, and making sure that you're complying with the safe harbors under the Anti-Kickback Statute or the exceptions under the STARK law. So speaking of the STARK law, let's shift gears and talk through that. General rule under the STARK law, it's also called the physician self-referral ban. I included the site up there, but the general rule is it refers physicians from referring Medicare, Medicaid patients for designated health services to an entity that physician, or an immediate family member has a financial interest with, unless there's an exception that applies. It also applies to the entity that's billing out for those DHS services. And just a couple of additional comments here on the STARK law. Designated health services, you could look it up within the site, but essentially it's most inpatient, outpatient type services that do qualify for DHS. As it's mentioned, they're kind of like the safe harbor. If you comply with an exception, it gets you out from underneath the general rule and the general prohibition. I think there's about 25 or 26 different exceptions to STARK, so it's a very complex law that has developed over the years. When it started out back in the 80s, it had to deal with essentially ownership type arrangements based on some studies that were sent to Congress, where if you had a group of physicians that had ownership in a laboratory or an imaging facility and they had the ability to refer patients, the physicians that were owners of those laboratories or imaging facilities tended to send more Medicare and Medicaid patients to those facilities than the non-owner physicians. And that caught the attention of Congress as stewards over the Medicare trust fund that's generated through taxpayer dollars in part. And so, sorry, I just lost my train of thought. But so basically, that is sort of where things had started. It has watered down and been expanded over the years to now not only include ownership, but also compensation arrangements. So if your organization has medical director agreements, has physician employment agreements, leadership positions, on-call arrangements, if you've got an emergency department, these are all things that essentially come within the purview of the STARK law now. So it doesn't have to be just an ownership type situation. And then strict liability is the other thing I wanted to mention. So I always tell at least our staff, when I'm doing trainings, is it operates kind of like a speeding ticket. So it doesn't matter what your intent was. If you cut your finger and you're headed to the ER, but you're speeding down the interstate, if you're going over the speed limit, technically the highway patrol could pull you over. And that is essentially how the STARK law operates as a strict liability statute. In terms of penalties, I included them up there: denial of payment, refunds of amounts that are collected from improperly submitted claims. There's a civil monetary penalty of up to $15,000 for each improper claim submitted, and then $100,000 per claim if it's for circumvention type schemes. And again, just a reminder, this includes not only the provider, but also the entity that's billing out for those particular services. So shifting gears, just talking through some notable settlements in the Stark Law area. I mentioned this one earlier. This North Broward case was one that had come out last year, and it's notable for a few reasons. North Broward, if you're not familiar, is in the Fort Lauderdale area, and it's essentially a health system. And this had to do with their, again, employed physician contracts that they had involving 9 specialists, orthopedic physicians, cardiologists, neurologists, as an example. And what they were doing is, for a number of years, they had been engaging in what was called a contribution margin report, which essentially was sort of a secret compensation formula that North Broward was using to compensate their employed physicians based on their referral patterns. And so how this worked was, if you were an orthopedic physician and you signed an employment agreement and you agreed to be an employee of North Broward, what they would do is they would monitor your referral patterns. And if you sent one of your patients to an imaging facility or lab for services, and that facility was owned by North Broward, then you as the physician got a bonus in your next paycheck. If, on the other hand, you sent them across town to the competitor, then you basically were subject to a penalty where they would actually take back money based on a predetermined formula. So it was a penalty if you'd sent them out. So definitely monitoring and then controlling where they're sending patients and incentivizing them to send their patients in-house. And this case had come up because there was an orthopedic physician, his name was Dr. Riley, and he was genuinely interested in signing on to be an employed physician with North Broward. And they'd sent him over a copy of the physician employment agreement, and he had sent it off to his attorney, and his attorney was looking through it, and buried within the boilerplate language of their agreement was language under the compensation section talking about these contribution margin reports. And of course, all kinds of red flags went off with the attorney, and he had advised Dr. Riley, absolutely do not sign this. And so Dr. Riley had expressed those concerns back to North Broward, and North Broward refused to essentially do anything with their agreements. And he had tried several times. I think he had went to the administration, he had gone to the board, and it took a number of years that he was trying to get this resolved because he was genuinely interested in becoming employed. And the entire time North Broward was resisting, and so eventually that led him to serving as a whistleblower and filing a False Claims Act case tied in with an improper financial relationship under the Stark Law. So again, just an example of how one of the typical cases you see in False Claims Act is also a violation of either the Stark Law or the Anti-Kickback Statute. But so that is sort of what led to this case. And where North Broward had come out was they eventually did settle. Again, the compensation formulas that they had with these contribution margin reports clearly was taking into account the volume and value of the physician referrals. That was tying into both Stark and Anti-Kickback Statute violations because of the excessive amount of money that was being paid out for steering patients inside. And that had resulted in a $69 million settlement. And it may not sound like a lot of money, but that was, again, a year ago in September. This was actually to date the largest settlement related to physician compensation under the Stark Law. Now, it didn't last long because the next case to come up was this Adventist Health System case, which got settled actually about a week later. And the Adventist Health System, it's a system that operates in Florida, North Carolina, and Tennessee, and Texas. And kind of a similar situation in that what they were doing is they were buying up physician practices that involved general surgery, family practice, and dermatology, and a few others. But the ones that were highlighted in this particular case were these 3 particular different practices. And what they were doing is they were intentionally, in order to get them to become employed, and then once they became employed, they were throwing all kinds of money and other perks at them with the hope that they would then steer their patients inside to Adventist health system facilities. So a couple of examples. The general surgeon, there was a payment by Adventist on his behalf for not one but 2 BMWs. The family practice physician, from the particular case, that one of the physicians involved had gotten $366,000 in a base salary, which for that particular geographic region of the country was considered double what fair market value was. And then one of my favorites was the dermatologist. The dermatologist had gotten $368,000 in bonus in addition to salary, which resulted in a total salary of $710,000 per year. Not too bad, especially when you consider that that particular dermatologist only had a 3-day work week. So those were the particular examples that were highlighted in this particular case that had led to the settlement. So with Adventist, compensation, again, clearly exceeding fair market value, tied into the Stark and Anti-Kickback Statute violations. And then this one settled for $118 million, so it was almost double what the North Broward case had settled for. And to date, this is still the largest physician compensation settlement agreement. So, you know, it'll be kind of interesting to see sort of where things go. This has definitely been a trend within the last few years, so something that I would pay particular attention to, you know, if you have employed agreements or employed physicians within your organization, excuse me. The last thing I want to talk about is medical directorship agreements. This is another area that has been catching a lot of increasing attention in the eyes of the government, and something that you'd want to pay particular attention to if you have medical directorships within your organization or associated with them. But I enlisted some cases up here. You could definitely go out and do a general Google search to find the actual cases in the settlement agreements. But these were ones that had come up a few years. They were all dealing with medical directorship type situations where either the physicians were getting paid an excessive amount of money for doing little or no work, or they were essentially set up as a way to kind of hide money that was going to these physicians, the intention of which was to get the physicians to send patients to their facilities. So medical directorships, again, is just something that you want to make sure you pay particular attention to. So with regards to some takeaways for the Stark Law, the first one is, again, just to kind of repeat, but I would monitor your physician contracts. You know, if you've got employed physicians or independent contractor ones. I apologize, I didn't include the site for the Anti-Kickback Statute or the Stark Law. You could definitely do a general Google search, or I'd be happy to provide that to you offline. But essentially, just, you know, you want to make sure that you're in compliance with those particular safe harbor and exceptions, that the agreement you have an agreement in place, it's signed. If there's any money changing hands, it's spelled out in the agreement, and the agreement is signed before services are rendered, so it's considered sent in advance. There should be a max compensation that is included in the agreement to also be considered set in advance. And then obviously making sure that you've got some type of third-party evaluation opinion, whether it's MGMA data or another third-party resource that is independently establishing what the market will bear for that particular physician specialty provide that particular type of service. So definitely something you want to do a spot check on. The medical directorships in particular, something just to point out here I would pay particular attention to is just, again, if you're not involved in the payment processing, you know, of payments to medical directors, and some organizations will do that where they'll actually inject the compliance officer in the process so that the compliance person has reviewed the contract, reviewed the timesheets, the work that's being done to make sure that everything's being paid according to contract before the CEO or CFO signs off. So if you're not involved in that process, you know, at least make sure that you've got that listed on your work plan to do a periodic and routine spot check on your medical director agreements to make sure that money that's being paid out is according to the terms of the agreement. You know, in particular, There should be a description of duties that's included in the medical directorship to spell out what that particular physician is supposed to be doing. There should be a listing of how many hours, either per month or per quarter or per year, and then again a max amount that's being paid out. There should be some type of hourly rate or monthly rate. And then again, compensation should be fair market value. The medical directorships, in terms of, they should make sure they are submitting timesheets, and then if they are submitting timesheets, there's documentation on those timesheets to establish with sufficient detail the work that's actually being done. And in some of those cases I had on that previous slide, that was the problem that was going on. There was actually no documentation or records of timesheets being submitted. There was little or very shoddy documentation to establish that the physician was actually doing work that he or she was being paid for. And so this is, as I said, those cases that were settled were actually a few years ago, but I am predicting that we'll probably start to see another rash of these in the next few years, in particular because this seems to be an area of focus for the federal government. Last year, they had come out, the DOJ and the OIG had come out with a fraud alert back in June of 2015 that addressed this concept of compensation stacking, and the fact that they were going to start to look very seriously at medical director type agreements to see if they were being used as a mask to essentially pay off physicians for getting them to steer patients. Compensation stacking, how that essentially works, or conceptually what that means is, you know, if I'm a physician and I have a contract with ABC Hospital to provide on-call services to the ER for maybe cardiology, do I also have a medical directorship for the cardiac cath lab? And in addition to that particular medical directorship, am I also serving on a peer review committee where I'm getting paid an hourly rate? And in addition to that, am I also under a different contract to be on a steering committee for the recruiting of cardiologists to the community? And am I also getting compensated under another agreement to be on a steering committee to oversee the implementation of an electronic medical record system, or what have you? There's a number of different scenarios you could probably come up with, but the point being, are there numerous different agreements out there all paying the same physician an hourly rate? And when you combine all these agreements together, does it look practical that that particular physician could actually do all those hours of work in a particular work week in addition to maintaining a full-time practice? That essentially is the concern that the government has and they're looking at, because they're seeing those as potentially an area where those that are the recipient of referrals might be trying to hide excessive compensation being paid out to a physician. So medical directorship is another area that you want to make sure that you're paying particular attention to. Shifting gears to legislative updates, just in the fraud and abuse area, there's a couple things I want to point out in terms of updates. Earlier this year, we got final word on what's called the 60-day overpayment rule. I did include the site there. It came out last February. This was in follow-up to the overpayment rule that was a part of the Affordable Care Act that came out in 2010. And conceptually, this is what's referred to as a Reverse False Claims Act payment. And so, or a Reverse False Claims Act type case. And so what that means is if you're a provider and you receive money from Medicare or Medicaid for services that you were not supposed to be paid and you got overpaid for those, if you identify that you got overpaid and you fail to return the money or report it to the government within 60 days, then it's going to be considered a False Claims Act or a false claim that you could potentially get prosecuted for. Or have to settle for. So that was the general rule that came out, and then there was some problems that had come out over the years in trying to identify, trying to determine and define, well, what exactly does identified mean? At what point is it considered that I have identified an overpayment that would trigger the 60-day rule that I would then have to report and refund? Because that's obviously a very short time frame. And that is sort of one of the areas that the final rule finally gave us some clarification on. And so what they've said is identified is considered that when you've done reasonable due diligence, if you have quantified what the payment is, that's going to be considered identified in the eyes of the government. So that was one of the sort of big pieces of clarification that came out of this particular rule. And so, again, just completion of reasonable due diligence has to be within 6 months to quantify. The other area that there was some clarification on was, well, okay, if we've identified we got an overpayment, how far do we need to go back and determine, what the scope of this particular problem is? And early on, there was some guidance that came out that said that you really should be looking back 10 years. And the final rule gave some clarification to that and said, we're only going to look back 6 years. So in some respects, that was, I think, welcome news in the eyes of the providers. I put that there at the bottom, but sort of the general rule here for the final rule is just follow the sixes. So it's kind of the rule of the sixes. So you got 6 months to identify that you've got an overpayment. Once you've identified it through quantification, you then have 60 days to report and return the money. And then in terms of the scope, you look back 6 years. Next piece of interesting legislative update that had come about, and I think, again, this is sort of kind of welcome news, I think, to those in the provider side of the healthcare market. With the the Medicare physician fee schedule that came out, actually it's 2015, I apologize, it's not 2016, but it should be the 2015 Medicare physician fee schedule, and that actually came out in November of 2015. We obviously haven't hit November 2016. But this came out last year. It was effective on January 1 of this year, and what it did was it made a number of changes to physician agreements under the Stark Law. Again, I think are going to be kind of welcome news and things that you could take into account when you are looking at your physician agreements. But and I didn't put them all up here, but just the most notable ones are that I think people deal with on a day-to-day basis is it finally gave some clarification to what had been sort of a long-standing understanding within the industry, was that you don't necessarily need a single formal contract in order to meet the Stark exceptions that require a written agreement. You can piece those together through emails, through the conduct of parties, through payments being made, those kinds of things. And for a number of years, if you'd attended any presentations from government agents speaking on this particular topic, that's something that they consistently have messaged, that they don't necessarily have to have a contract for their investigation. They're going to potentially pull all different kinds of records, and they can infer that there was an agreement made based on the conduct of the parties. So to kind of settle everything, because there were some cases that went both ways on that, they clarified and said don't need a single formal contract. For leases, whether it's equipment or services or a professional services agreement, again, a couple of the exceptions under the Stark Law, you don't necessarily have to specify a written term that's required. So from November 1, 2016 to October 31st, 2017 or something like that. Also, there is another exception with regards to what's called the technical noncompliance with the signature requirement. So this essentially is a situation where let's say I'm with a hospital and we've contracted out with a physician to start services on November 1st. November 1st rolls around and we're not able to actually get the physician to sign the agreement before he or she starts to provide services. You could then fall back on this particular exception, which under the old rule would have given you 30 days to make sure you get that signature if it was something that was intentionally missed. If it was accidentally missed, then they gave you 90 days. And so with these new changes, they have sort of relaxed things a little bit and said, doesn't matter if it's intentional or accidental, we're going to give you 90 days to make sure that you get that signature. And there's are other conditions with that particular exception. So if it's something that you are going to rely on, just make sure that you check the actual language of the regulations to make sure that you can fit within that definition. And I would do that before you run into a situation where you have determined you have to invoke that. And then the other one that's pretty notable is the holdover provision within Stark. This is under the professional services arrangement exception. But this is the type of situation where if you have a contract with a physician for at least 12 months and it's not a situation where it's an auto-renew agreement, you actually do have to come back and enter into a new agreement or make an amendment to extend the term. If you don't do that before the end of the term, the holdover provision was something that you could invoke once every 3 years, where you could, it'd give you basically another 6 months for the parties to come back and renegotiate a new agreement. During that period of time, you had to continue to operate under the same terms of the existing agreement, but that was another provision that gave a little bit of leeway with regards to managing your agreements. Under this new rule, they've now done away with the 6 months, and it's sort of essentially indefinite. So you can get into a holdover period so long as the parties continue to operate on the same terms and then work towards renegotiating a new agreement. With regards to legislative activity, another thing I wanted to mention was the Senate Finance Committee the last couple years has really started to take a renewed interest at the Stark Law, and I think is what's going to be hopefully a welcome change to the healthcare market or healthcare provider side of the market, is relaxing some of the requirements and making sure that it is more in line probably with reality, I guess I would say. A couple things what they're doing is they're looking at the cost, the tremendous cost of compliance, the disclosures that are involved, the types of disclosures that are being made. Some of these very technical requirements that are not being met, where there's not, an egregious set of facts or bad intent or things like that. And just kind of looking at and seeing, are these penalties really fitting the type of crime? And so they've been holding a few hearings. There was one, again, a couple months ago on this particular topic. And it has produced a couple different bills that are out there, and I put the sites up to take a look at. But basically what they're doing is they're just taking another look at to see if there needs to be some changes to start to really kind of make it in line with the reality of how healthcare is delivered today, and trying to reduce sort of the administrative burden that goes along with trying to comply with START. So that is the fraud and abuse area. We're going to shift gears now and talk through patient confidentiality. Due to the scope of the webinar, I didn't want to go into too much extensive detail on the state law side. So what I want to do is just sort of generally summarize kind of where we've been on the patient confidentiality side in terms of scope. So obviously the federal law, we have Hipaa, and I included just the legislative history over the years. The most recent legislative activity has been within 2013 when the Omnibus Rule came out. That made changes to the breach notification rule and a few other areas. So that's sort of the latest we have in terms of legislative activity for Hipaa. I haven't seen anything recently. I'm not sure at this point if we will see anything in the next couple years. I think because of some of the focus with the OCR right now and doing audits and investigations relative to Hipaa compliance, I think they have their hands full with the work that they're doing. That I'm not sure if there will be additional changes that are made. And really the last few changes that came about with the breach notification rule and the Omnibus Rule was to try and tighten up some of the enforcement, which is what the OCR is now trying to test with some of their auditing, which I'll talk about in a little bit. But so that's the federal side. The state side is your state laws. So again, it's beyond the scope of the webinar to talk through the various state laws, but just something to generally make sure that you're aware of, that you are taking into account state laws and what your particular state's laws are in that area. You can do a general Google search just to find out what your state's laws are, and when you get those sites, then I would recommend going to the actual official listing of whatever your state statute and regulations are, just to make sure you got copies of what the current regulations are. But state laws can be a little bit different. They can provide greater privacy protections. Here in Colorado, where I'm at, we've got, for example, teen confidentiality. So if teens wanted to get various treatments such as STD-related treatment or family planning or alcohol and drug abuse or certain mental health services, there are circumstances where teens can actually restrict their parents from or others from seeing that information. And that was done in our state to and make sure and encourage those teens to actually seek and get treatment rather than avoiding it and causing bigger problems down the road. But that's something that here in Colorado we have to take into consideration based on issues that can come up between parents and teens related to who gets to see and who doesn't get to see information. So in the area of notable settlements for Hipaa, just a few cases I wanted to talk through that I think are notable. This first one is Cancer Care Group. This was a 17-physician radiation oncology practice located in the Indianapolis area. And what they had happen, I think, is unfortunately pretty common in today's world. They had an employee that was issued a laptop from the company, and the company had allowed employees that were issued laptops to do work at home or off-site remotely. And the particular employee was taking the laptop off campus and went out to dinner, and the car where the laptop was being kept got broken into, and a thief stole the laptop. And so this particular physician practice and that particular laptop, it was also a server, so it contained 55,000 current and former patients from the physician group. And so unfortunately, like I said, stolen laptops happen in this day and age. What is unfortunate about it, and I think what's important to note about this particular case, was the fact that this laptop was not encrypted on one hand, which I've definitely attended numerous presentations over the year from OCR investigators and auditors, and know that in this day and age, it's pretty common to have any of your removable media devices encrypted. And if you don't have them encrypted, you better have a pretty good explanation as to why they're not encrypted. And so that was sort of the first whammy against this particular physician practice, was that they didn't have the laptop encrypted in this day and age when it's pretty common to have them encrypted. The other piece of it was, not only was it not encrypted, but there was no risk analysis that was done under the security rule to determine if they had any vulnerability with regards to their electronic PHI. And in particular to this laptop, you would think once the laptop was stolen and it was identified that it was not encrypted, that the group would have taken steps to make sure that their laptops going forward are encrypted, and that was something that they had failed to do. And so the other reason this case is important is because of the size of that settlement, $750,000 for a physician practice involving 17 physicians. That's a huge paycheck to the government for settling it. And so I know with me in particular, if I had to go into my CEO and explain that we had an unencrypted laptop that was stolen, and we knew it was not encrypted, and we failed to take steps to encrypt it, and we had to write a check for $750,000, that would not be a conversation that would go over very well with my CEO. But nonetheless, that's the reason why I want to point this out, is just to make sure that you are doing that risk analysis under the security rule. And risk analysis, just to pause on this for clarification, is not risk assessment. I think people sometimes get confused on that. Risk assessment is part of the breach notification rule, which is on the privacy rule side of Hipaa. Risk analysis is making sure you're going through and analyzing all your electronic protected health information and identifying how you're safeguarding it, steps you're taking to safeguard it, and identifying any vulnerabilities. And if you've identified vulnerabilities, making sure that you're taking steps to correct it. So some examples, obviously unencrypted laptops. If you are involved in transmission of data over the internet, is that data being securely transmitted? Are you entering into BAAs with those that have access to your electronic PHI? Removable USB drives is another area. You can have a USB drive, and if somebody puts a bunch of PHI on it and they pull it out of their computer and they go to the grocery store on their way home and they pull it out of their pocket and they leave it in the grocery store, now you've got a breach. So it's sort of reducing those instances where you may have the potential to breach PHI. Next case I want to talk about is this Leahy hospital case. This is a health system, I believe it's in Massachusetts, and I think it's just outside of Boston, but what had happened in this case, again, it was another stolen laptop situation, and it was an unencrypted laptop, but a little bit different factually in that this was a laptop that was accompanied next to a CT scanner in a treatment room, and it actually helped access PACS images and helped operate that particular scanner. So it was in basically a control room to a CT exam room. And the control room was left unlocked. It was during the overnight hours, and somebody had come in overnight and walked away with the laptop. And it contained about 600 patient names and resulted in an $850,000 settlement. This one's, again, it's particularly important to note because here they had another situation where they didn't do, there was no evidence they'd done any kind of thorough risk analysis. They didn't have any real policies and procedures regarding safeguarding protected health information. There was sort of an unwritten rule within the organization that they left this control room unlocked, which of course left them vulnerable and had the potential for PHI to get breached. And then they were not doing any type of appropriate auditing relative to who was accessing their PHI, which is another thing that you want to make sure that you do is reasonable and appropriate random access audits to make sure that, you know, for example, if you have a policy in your organization that people can't access their own medical records, are you spot checking to making sure that people aren't actually doing that? And if you do find out they are doing it, making sure that you've implemented some form of corrective action. Another case to talk through is this Triple S Management Corp case. This one came out about a year ago. There were several breaches, and this one's interesting to note for a couple reasons, one of which is this $3.5 million settlement. It's a very large settlement under Hipaa. Triple S Management Corp is essentially an insurance holding company, and what had brought this case about was they had had multiple breaches from about November 2010 through August of 2015, where I think there was 4 or 5 different breaches that involved over 500 people. And that was what had triggered the OCR investigation and caught their attention. And so through the settlement and through the investigation, the OCR found out that that they had failed to safeguard protected health information. There were instances where they didn't have business associates agreements with vendors that were accessing their PHI. Or they were outdated BAAs. And again, they didn't do any kind of thorough risk analysis under the security rule to identify any particular vulnerabilities that they might have. And just to give you a quick example, one of the breaches that was involved an employee that was terminated with the corporation and left, but the corporation never took the steps to actually terminate that particular employee's access to their systems. And so several months after the fact, this employee was able to access all kinds of records with PHI. And that was one of the breaches that was involved. So those are the kinds of things within your security rule risk analysis that you want to make sure that you're working with your IT director and those that are involved with your information systems to make sure that you're reducing those vulnerabilities. And then the last case I want to talk through is this Lynn case. It was settled a little bit earlier this year. This was actually kind of an interesting case, I think just factually. Not a ton of patients involved, about 300. And when I initially read it, PHI of almost 300 patients was removed from the office and abandoned. I thought, well, it might have been a respiratory therapist that was going and doing home visits and probably had a clipboard with some PHI on it. And that particular employee left the PHI in one of the patient's homes, and it was the patient that actually complained. But reading into it a little bit further, you come to find out that actually this involved a couple of employees of Lincare, and it was a husband and wife that were both employed by Lincare. The wife was a manager and the husband was an employee. And I'm not exactly sure what had happened, but at some point the relationship had soured and it was evidently a pretty nasty divorce. And the husband was still in the marital home. And there was an unwritten rule within Lincare that allowed their managers to remove PHI and take it home with them to do work at home or in the evenings. And we're talking sort of physically not electronic, but sort of physical paper documents that had PHI on them. And so through the course of the divorce, the husband, I guess in an attempt to try and get back at the wife, had filed a complaint with the OCR and essentially said, I have all these documents, these PHI, and Lincare has violated Hipaa. And so that is sort of what led to the investigation. And Lincare had actually pushed back and said that they were sort of siding with the wife and that they felt like the documents were not left by the wife in the marital home, but they were stolen by the husband. And it should have backed up a second. I'm not sure if I mentioned earlier, but for whatever reason, the wife had moved out of the marital home, so it was just the husband that was living there. But they had pushed back and said, no, these documents were stolen. And the OCR said, no, they were left there. And so basically, again, sort of their findings from this case was they didn't have adequate policies and procedures regarding the removal of PHI off-site and safeguarding protected health information. Again, they had a lot of unwritten rules that allowed staff to even put PHI in their car and leave it over extended periods of time. So situations that the OCR felt like these were kind of no-brainer things that organizations should be doing in this day and age. And so that was the reason for that particularly high settlement. Looking at enforcement activity on the Hipaa side of things, the Phase 2 final rule, or the Phase 2 auditing, began earlier this year. Phase 1 was a couple years ago. It includes covered entities and business associates. So business associates for the first time are getting pulled in. And it's looking like there's probably going to be annual auditing after this year. With regards to the Phase 2, I think there was about 14,000 people that were potentially in the pool that received notices back in March and May of this year that they may potentially get selected for the Phase 2 audit, which was going to be a desk audit. In July, there were notifications that went out to covered entities that notifying them that they were going to be subject to the audit. Business associates, I have not heard clear guidance one way or the other. It's my current understanding that the business associate side of things they have not been announced that they've been selected, but I would assume that probably that should be coming any day because the OCR was had a deadline of the end of the year to try and get these wrapped up, and they were supposed to take about 5 weeks to complete. But at any event, so the notifications have gone out, at least for the covered entities, and there's potentially going to be annual auditing, or they've said there's going to be annual auditing down the road. So if you didn't get picked this year, you may be one of the lucky ones in the future. So again, just another reason why I want to make sure that you have your ducks in a row with regards to your compliance on the Hipaa regulations. So specifically on the Phase 2 audits, just some things that that they're taking a look at. Privacy rule compliance. I listed some examples. They're going to look at notice privacy practices and policies and procedures. They're going to look at your business associates agreements, making sure they're in place and if they're current and are they being complied with. Incomplete or inaccurate risk analysis. Again, that's something obviously we talked about a lot of cases a little bit earlier that hit home that point that that's something that's definitely an area of focus. So you want to make sure that you're doing that on a routine basis. And then, are there situations where you identified risk, but you failed to do something? And again, we talked about those laptops that were not encrypted, but they knew they were not encrypted. So just making sure once you identify an issue that you are putting corrective action measures in place. And then making sure that you're complying with the breach notification rule in terms of doing the risk assessments. You've got documentation of it. If you've determined that it's a medium or high risk, are you notifying those particular individuals? So just a couple final comments. Definite focus right now for the OCR. They've said it time and time again. I think these cases definitely demonstrate that their focus right now is on the security rule more so than privacy rule. I think because of all the data breaches that have been going on both inside and outside of healthcare. Make sure your policies and procedures are current, that they're being followed. Making sure you specifically have procedures on how you are handling hardware once it's removed or brought into the organization and information is wiped from those devices. periodic auditing and monitoring, just making sure that you're doing that. You can take a look at some of the areas that the OCR is looking at to use that in terms of developing particular auditing that you might want to do. And then again, the last thing I'd comment is just making sure that you're conducting some type of organization-wide risk analysis. And again, if you go onto the OCR website, there's all kinds of guidance and information on there, and you can look at exactly what they're looking at, and it's essentially an open book test. So I hope that information was helpful. And with that, I'd take any questions that you might have.
Thank you, Jay, for the presentation. Now we will open the lines for Q&A session. Anybody having a question can raise their hand by clicking hand button, which is down right corner of your screen. Also, you can send your questions through in the chat window. Yeah. It seems there is no questions at this moment. However, you can still send your questions to email ID at webinar@compliancekey.com. With this, we will end the session. We appreciate your time and believe the session was informative and up to your expectation. We look forward to see you in your next event. Soon you would be receiving certificate of attendance and a feedback form. Kindly send your comments. Your feedback is important for us. Thank you very much for your time and have a good day. Thank you, Jay, for the presentation.
Thank you.